Hello, everyone. Seeing you all coming in, we'll get started in a second here. All right. Good afternoon and welcome to our congressional briefing and national webinar on the report Ready or Not 2024, Protecting the Public's Health from Diseases, Disasters, and Bioterrorism, hosted by Trust for America's Health, or TIFA for short. My name is Tim Hughes, the External Relations and Outreach Manager at TIFA. We would like to thank you and our speakers and audience for being with us today. Real-time captioning is provided today by Lee from AI Media. For captions, click on More at the bottom right of your Zoom screen and enable captions. Next, click on Close Captions. ASL interpretation is also being provided today by Keystone Interpreting Solutions with Judy and Hannah as our interpreters today. If you'd like to use ASL interpretation, hover your cursor over the interpretation button on the bottom of your Zoom screen. We encourage you all to share your thoughts and questions about today's presentation by typing them in the Q&A box. We'll try to answer as many questions as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom on your screen. From there, select Enter when you are ready to submit your question. As always, today's webinar is being recorded. That recording and slides will be available on TIFA's website by the end of the week, along with all the previous webinars we have held. And now it is my pleasure to introduce the moderator of this event, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She is a national health equity leader with extensive leadership and management experience in federal government, the nonprofit sector, academia, and professional associations. As president and CEO, she leads TIFA's work to advance sound public health policy, address the social determinants of health, advance health equity, and make health promotion and disease prevention a national priority. Before joining TIFA, Dr. Gracia was the Deputy Assistant Secretary for Minority Health and Director of the HHS Office of Minority Health during the Obama administration. Welcome, Dr. Gracia.
Thank you, Tim, and thanks to everyone for joining us today for this important discussion. As Tim noted, my name is Nadine Gracia, and I'm the President and CEO of Trust for America's Health. And I'd like to first thank you all for joining us and thank our esteemed panelists for taking the time to participate in this briefing. We are so honored to have you here. Next slide. Our agenda for today is on this slide. After providing you with an overview of the report and the panel presentations, we are going to have time for discussion and questions from the audience. Our goal for this briefing is that you'll leave with a better understanding of the policies and programs that impact our nation's preparedness and response for emergencies and disasters of all kinds, from outbreaks and pandemics to extreme weather to man-made disasters. Next slide. Now, before we introduce our panel, I'd like to begin with a brief overview of Trust for America's Health 2024 Ready or Not report. And a copy of the full report, including state-specific information, is available on our website, tifa.org, and we'll also include a link in the chat. The Ready or Not report examines the country's readiness for public health emergencies through state data, as well as really putting it into the broader national context of national preparedness. And notably, this year's report includes a special feature on the health impacts of extreme heat and its disproportionate risk for some populations. And as always, we include recommendations for policymakers to improve the nation's health security. The issue of public health emergency preparedness is as important as ever for both the health and economic security of the U.S. 2023 was indeed an historic year in which the nation experienced a record number of billion-dollar weather disasters. Just last week, we saw the National Oceanic and Atmospheric Administration, or NOAA, predicted that 2024 could see a record number of hurricanes and cyclones. Across states, public health and agricultural officials are working to track and contain the avian influenza outbreak that is infecting dairy cows, and to date, 2 cases in dairy workers. An increasing number of cases of a more severe form of Mpox is occurring in the Democratic Republic of the Congo, raising concern within the US as well. All of these threats illustrate the need to redouble our efforts to prepare for and respond to public health hazards wherever they begin. These threats also highlight how the public health and emergency response systems are regularly responding to multiple forms of emergencies at the same time. Next slide. An important feature of our annual report is looking at state-by-state indicators across a range of areas that give states a baseline from year to year, as well as actions that states can take to improve their readiness for emergencies. Some findings from this year's report are included here, including a notable increase in the number of states that are participating in the Nurse Licensure Compact, which allows hospitals to be able to surge their staffing capacity during emergencies. There's excellent planning for surge testing across public health laboratories. Most states are accredited in either public health or emergency management, and 29 states are accredited in both. On the other hand, as areas for improvement, and I'll note that all states and the nation as a whole can take steps to improve in their preparedness. 11 states reduced their public health budgets over the prior year. We've seen a reduction in vaccination rates for flu, and the use of paid time off among workers varies across states. Next slide. Now, with that overview of the states, we must also acknowledge some significant progress in the last year, and I'll highlight just a few examples. We've seen the approval of vaccinations and immunizations to prevent RSV in older adults, pregnant people, and young children. The White House stood up the Office of Pandemic Preparedness and Response Policy to coordinate across federal agencies. There have been new extreme heat resources from multiple federal agencies to help states and communities identify their residents who are most at risk and help them prepare for extreme heat. And funding from the American Rescue Plan Act has been invested across the country to strengthen public health infrastructure and workforce. Next slide. But what remains a significant challenge is that public health infrastructure funding is an important illustration of what we call the boom and bust cycle of public health funding. The chronic underfunding of public health has put our nation at risk by failing to invest in foundational capabilities, such as disease detection systems, modernizing data systems, and the workforce. When a crisis hits, what we often see is short-term emergency funding, which is indeed vital for the emergency response. But once that crisis has receded from the headlines, we return to a period of austerity. Already, Congress has rescinded billions of dollars of public health funding that was intended to extend beyond the acute phase of the COVID-19 pandemic. One recent consequence of this will be that the federal Vaccine Bridge Access Program, which provides free COVID-19 vaccines to adults who are uninsured and underinsured, will be shut down months ahead of schedule. And we're going to address this issue of public health funding in today's briefing. Next slide. Now, as I mentioned earlier, this year's report includes a special feature devoted to the impacts of extreme heat on health. Why focus on extreme heat? Well, it's the leading cause of weather-related deaths in the US. And yet, heat-related deaths and illnesses are preventable. We know as periods of extreme heat increase in frequency and intensity, as well as reach a broader swath of the country, some populations bear a disproportionate risk, including people who work outdoors, older adults, and young children. Our report includes recommended actions for the federal government, as well as state and local governments to better prepare. And I look forward to learning more from the experience of one of our featured speakers today, Jane Gilbert, the Chief Heat Officer for Miami-Dade County. Next slide, please. Now, our report also importantly includes policy recommendations for a variety of different audiences, including Congress and federal agencies. And I'll just mention a few here, and I encourage you to review the report for additional information. Many of our recommendations for Congress could be accomplished through annual appropriations, through passage of the Pandemic and All Hazards Preparedness Act, or other mechanisms. First and foremost, we believe that to build a strong foundation for the nation's preparedness, we must invest in public health infrastructure, workforce, and continuous public health data modernization in a sustained manner, not the cyclical pattern of boom and bust. Next slide. Now, what we also see is that the recent outbreaks of measles, mpox, and avian influenza in dairy cows continue to illustrate the importance of the nation's vaccine infrastructure and access, especially through CDC's immunization program. We highlight as well the importance of job-protected paid leave to prevent workplace outbreaks and protect the health of workers and customers. Policies such as job-protected paid leave really demonstrate how all sectors have a role to play in the nation's and state's preparedness. It's also critical that equity and the meaningful engagement and partnership with communities be prioritized throughout readiness and incident management, as we have long seen the health and socioeconomic disparities that are exposed and further exacerbated during emergencies and disasters. We shouldn't be planning for populations that are at increased risk of poor outcomes only after an emergency or disaster strikes. Next slide. And in our last area of recommendations, we support increasing investments in healthcare readiness and response, programs that are administered by the Administration for Strategic Preparedness and Response, or ASPR, including building readiness for pediatric patients in emergencies. Continuity of care during disasters requires planning and coordination across facilities, and we know that the nation's healthcare system is also under strain. And finally, recognizing the serious and growing threats that environmental hazards and climate-related events have on health, we call for improved indoor air quality standards and funding for environmental health and extreme heat initiatives to protect communities from the different hazards that they may face. Next slide. So here you can learn more about our report. As I mentioned, we have the link to the report in the chat, as well as our other public health research and policy. So please do not hesitate to reach out to us. And with that overview of our 2024 report, I'm now excited to introduce our panel. Next slide, please. We're going to save questions for the end, but just a reminder to submit your questions in the Q&A box, not the chat, and we will get to those questions after the presentations. Our first speaker is Jane Gilbert, the Chief Heat Officer for Miami-Dade County. She leads resilience strategy development to address the increasing heat, health, and economic risks associated with extreme heat. Prior to this, she was Miami's Chief Resilience Officer, responsible for climate and urban resilience strategy for the city, and in partnership with Miami-Dade County and the city of Miami Beach, the greater Miami region. Dr. Raynard Washington serves as Public Health Director for Mecklenburg County Public Health, responsible for leading more than 900 interdisciplinary public health professionals who work daily to protect and promote health among county residents with an emphasis on improving health equity. Dr. Washington is also the chair of the board of directors of the Big Cities Health Coalition, an organization of the leaders of America's largest metropolitan health departments. And our third speaker is Dr. L. Brannon Traxler, who serves as Director of Health Promotion and Services and Chief Medical Officer for the South Carolina Department of Health and Environmental Control. In this capacity, she provides direction for public health, leading its more than 2,000 public health employees. She ensures the delivery of appropriate, timely, and quality services at the department's 74 public health service sites located in every county in South Carolina. It's now my honor to welcome our first speaker, Jane Gilbert, Chief Heat Officer for Miami-Dade County. Jane, I'll turn it over to you.
Thank you, Nadine. It is really a pleasure to be addressing all of you today. As Nadine had said, I am the Chief Heat Officer for Miami-Dade County. I was appointed to this role 3 years ago to address the increasing health risks and economic burdens associated with extreme heat, and to work not only across departments within the county, but with our various stakeholders within the county, our state health department, National Weather Service, universities, community-based partners, municipalities. We have 34 municipalities within Miami-Dade County. Next slide. So I've told you a little bit about the why of a chief heat, or what of the chief heat officer. I should say a little bit about the why, and I'm also going to talk about how we assessed how extreme heat is specifically impacting people in Miami-Dade, just to give you a sense of how it might be happening in other cities across the country, but some of the unique aspects in Miami-Dade as well. And then an overview of how we developed our plan and some of the components of that plan. So Miami is known internationally for its risks to sea level rise and hurricane risk, and we've been working on those for quite some time. But when a group of community-based organizations went into our lower income and more vulnerable communities through focus groups and surveys to find out what their top concerns were related to climate change, it was not hurricanes or sea level rise. It was extreme heat, because that's what they were living day in and day out. And really, it's through that growing awareness of how extreme heat is impacting people's lives and livelihoods that my position was born. Next slide. So we've had an increase of over 70 days with temperature over 90 degrees since 1970. And our average minimum temperature rise of 2.2 degrees Fahrenheit. Next slide. Going forward, we're going to see a dramatic increase in days with heat indices over 100 and 105. In the fifth National Climate Risk Assessment, it was found that Miami-Dade County is actually the county to have the most increase in dangerously high heat days, defined as 100 degrees Fahrenheit or above. Actually, I should say that last summer we had over 42 days with a heat index at or above 105. So even though historically it's been about a week, we're well on our way to getting to that 3 months out of the year, or could be anyway. Next slide. And we saw that with last summer's extremely hot summer, an increase in our emergency department visits. On the right hand, that's our peaks from summer from last year. And then the previous 6 years to that, you can see we had much higher peaks. This is from our state health department. Next. And it's getting hotter in cities globally, not just because of climate change, but because of how we develop our urban development patterns. More asphalt and buildings, less vegetation, less trees, more waste heat from those buildings, from vehicles. All of this contributes to urban areas being at least 10 degrees hotter than other areas. Next. And that's distributed unequally. On the left, you'll see area median income, the white areas being the lowest median income. On the right, urban tree canopy, the white being less than 10% urban tree canopy. You can see how aligned they are. Next slide. And we have the compound risk. So we have chronic high heat in Miami, not the extreme heat waves, but with a hurricane and an extended power outage, that is our disaster when it really comes to heat. That is our episodic disaster, because people won't have access to air conditioning as easily. And we saw that with Hurricane Irma in 2017, when we lost 12 people in a nursing home in the county just north of us. Next slide. So we did an assessment looking by zip code of heat-related emergency department visits and hospitalizations in the county. And the highest correlating factors in those zip codes were high poverty rates and high land surface temperatures. So our urban heat islands, low income, other social determinants of health, high percentage of outdoor workers, high numbers of families with children. Next slide. So we've mapped this, and this is really informing how we intervene in our action plan. Very much both the types of populations that are at risk and the locations, and I can speak more about that. Next slide. So we pulled together a task force, including healthcare professionals, National Weather Service, all the different stakeholders, did a series of public workshops, used the data from our vulnerability assessment and created a highly collaborative work plan. Next slide. I always say, if you want to go fast, go alone, but if you want to go far, go together. And it really was a critical aspect of our action plan, is that it is a collective action plan. While I have led the creation of the plan, all these different players from local, state, national, international are either leading or supporting some of the actions on the plan. Next slide. So it's split up. Our plan is split up into 3 main goal areas: inform and prepare people, help people stay cool at home affordably, and make sure we have sites with backup power and cooling capacity for that hurricane risk. And then the third is to cool our neighborhoods, primarily through tree planting efforts, but other urban heat island mitigation efforts as well. Since we have a public health group here, I pulled out, we do a lot of trainings, education. We can get into a lot of this in the question and answer, because I know my time is limited at this point. So we've updated our heat advisory and warning thresholds, done outdoor worker protection, and formed a partnership with local universities on ongoing research. With that, I'll turn it over. Thank you.
Thanks so much, Jane. Looking forward to hearing more about, in particular, those heat response plans, how you prepare for populations that are in particularly disproportionately at risk for extreme heat. So looking forward to talking about that in our discussion. We're now going to hear from Dr. Raynard Washington from Mecklenburg County, North Carolina Public Health. Dr. Washington, I'll turn it over to you.
Wonderful, thank you. And we can go ahead and advance to the next slide. It's certainly my privilege to be here this afternoon. As an epidemiologist by training and a local public health official, I'm very excited to join this critical conversation about preparedness. Our team here at Mecklenburg County, as has already been said, I'm really proud of the work that we do every day to protect and promote good health for the 1.1 million North Carolinians that we serve here in our growing and diverse community. It's also my honor to serve as the chair of Big Cities Health Coalition. As has already been stated, we are an organization of health officials who lead 35 of the nation's largest metropolitan health departments. Together, we do serve about 61 million Americans, or nearly 1 in 5 of residents in the country. It is really great to be a part of the coalition, really because we get a chance to have these kinds of conversations about preparedness on a regular basis with each other, and really champion how our governmental public health system can improve to better protect our communities and close some of the persistent gaps that we experience as it relates to health equity in too many of our communities across the country. Like many of you, I've got firsthand experience of the really critical role that emergency preparedness plays in our job as public health team members. After serving as Deputy Health Commissioner and Chief Epidemiologist in the city of Philadelphia, I came here to Mecklenburg in March of 2020. And as you might imagine, on my very first day of work, I was tackling a global pandemic that was really kicking off on March of 2020. And I went straight from my new hire orientation to our Emergency Operations Center to join our local pandemic response activities. Next slide. It's important to recognize, and I think that really my perspective here today in this webinar or briefing is really focused on the role that local public health plays in emergency response. Local public health departments are really on the front lines of preparing for, responding to, and supporting residents during all kinds of emergencies. I say very often we're there at the beginning, in the middle, and at the end, and in between. There are very few, if any, emergencies that don't have some impact on the public's health. And because of that, it's really important that we maintain at the local level coordinated networks, and that we have to prepare our partners on the ground for emergencies before they happen, so that we can be able to respond quickly and in an impactful way. This is really the unique role of local public health. Right now, across the country, local public health departments in big cities and in rural communities are responding to both acute crisis, like the weather-related events in Texas area, to infectious disease threats like the avian influenza that's already been mentioned earlier today. And this is all while we are still maintaining our routine surveillance and response activities, and of course, providing those vital or critical public health services in clinics and schools across our communities. Public health departments at the local and state level are able to respond because of the work that we put into maintaining what we call a true all hazards preparedness, which is so critical to our nation's health. Next slide. As we are seeing or experiencing the resurgence of diseases that we thought we had eliminated, like measles and polio, and even here locally, we just are experiencing an outbreak of pertussis in kids, it's clear that all hazards preparedness must be at the forefront of our priorities for our public health system. We have to be prepared to surge up for unexpected infectious disease emergencies, which requires us to have funding for both staff and infrastructure, and not, as Dr. Grassi has already said, this boom and bust or disease-specific dollars that unfortunately has become the norm for us in public health over the last several decades. As we all know too well, public health emergencies don't just arise out of infectious disease. We currently across the country are dealing with a drug overdose crisis that is extreme. We have gun violence epidemics in areas across the country, and we live in a nation where about 7 in 10 of deaths arise from preventable chronic conditions, with cigarette smoking continuing to be a leading cause. Our emergencies aren't sporadic. They don't just come and go. They're ongoing and ever present. With that in mind, it is so important for those of us who work in local public health to really focus our efforts not just on our communities, but on pushing for policies at the state and federal level that support or at least don't detract from the work that we're trying to do on the ground. I'd like to just in the minutes I have just highlight a few things we should be pushing for, or at least I believe we should be pushing for at the federal level in order to make our preparedness for emergencies better and make our local level work more efficient and more prepared. It is essential, first and foremost, that federal agencies have clear preparedness and response roles well in advance of an emergency. At the same time, while I appreciate and we all know that federal leadership and resources are so vital, it's also important to recognize that a top-down approach to public health is not sufficient. To truly prepare or function as a system, public health leaders must be involved at every level of government, that's local, state, and federal, and information, data, and resources also have to be able to flow quickly and efficiently from each of those levels. And until that happens, I argue that we will remain unprepared for health and health security challenges that we face. Consider, for example, next slide, the Public Health Preparedness Program that was created after 9/11 to support preparedness infrastructure and a response-ready workforce at the local level. Despite the increase in emerging and re-emerging infectious diseases and all the other emergencies that local health departments are tackling, Congress continues to cut the FEP funding by nearly 30% over the last 2 decades. It's actually for the last slide, but it's okay. In Mecklenburg, we've had to increase our public health preparedness staff from 1 FTE to 3 since 2020, really because of the need that we experienced during early on in the COVID pandemic. These vital human resources that allow us to train our clinical and non-clinical staff to host preparedness sessions for our community partners and really maintain local response plans for every type of hazards are so vital to our success when emergencies arise. But with federal funding for emergency preparedness dwindling, it's really difficult to sustain even the basic level of staffing in local health departments, not just in big cities, but even more so in the medium-sized and small cities and rural parts of our country. That's why, as a coalition, Big Cities Health Coalition is taking the leadership role and really urging, as Dr. Grassi mentioned already, the reauthorization of the Pandemics All Hazards Preparedness Act, or PAPA, which really enables so much more additional federal funds to come down to the local level to help us be prepared. Next slide. I also firmly believe that it's time now for our country to authorize an adult vaccine program similar to the Vaccines for Children program. As we learned from COVID, we really need a comprehensive vaccine infrastructure in order to protect Americans against both those known threats as well as emerging infections. I give you an example locally. During the mpox response, local health departments like mine received no financial support initially for both the staffing and all the other resources that were needed to be able to deploy vaccine into our communities during the height of the outbreak. But we were able to successfully, as we often do at the local level, mobilize partnerships on the ground with our community organizations, LGBT plus social organizations, and others to really work diligently to get vaccines out into the community, which were able to help us contain the situation. We've seen very similar scenarios play out recently with the measles outbreak in communities like Chicago and Columbus, where the Department of Health really has had to take the leadership role in mobilizing on the ground locally to get vaccines out to thousands of families with no additional resources available to them. Next slide. Finally, and really important to me as an epidemiologist, it is so critical that we have timely, accurate, and actionable data at the local, state, and federal levels. Our systems right now for surveillance, early detection, and the data systems that sit behind those still badly need significant upgrading and modernizing. We're really appreciative to our federal partners for the investments that have been made recently in modernization efforts for data at the local, state, and federal level. But from the perspective of local health departments, the CDC absolutely must have the authority to not just invest in the systems, but has the authority to actually collect the information so that we can have a coordinated response. We can share data across the variety of partners that need it. That includes both local, state, and federal, and actually make timely decisions with information that will help us make those decisions as best possible. It's a shame, though, that right now, because of the fragmentation of our system, that we're collectively tasked to make decisions that cost millions, billions, or even trillions of dollars with the framework for collecting and sharing public health data that really is fragmented and results in inconsistent reporting to both the CDC, the state, and our local public health partners. Expanding data authority for state, local, and federal agencies will allow us to have more complete and timely data sharing, as well as investing in those systems that collect that information will allow us to be able to translate that information to action much more quickly at the federal, state, and local levels. In closing, I just want to emphasize that a well-functioning public health system must prioritize pandemic and all hazard preparedness, and it has to be well-resourced at all levels of government before, during, and after emergencies. As I've been said before, diseases and disasters really don't recognize city, county, or state boundaries. And across the nation, every community is only as prepared as their weakest neighboring community is. And so with that, I will pass it on to the next speaker. Thank you all.
Thank you so much, Dr. Washington. Thank you for so many points of emphasis. The all hazards preparedness, as you noted, that happens in addition to the day-to-day essential functions that public health serves its communities each and every day, and looking forward to speaking to you more about that. And then also noting the importance too around the policy recommendations, both to the state and federal levels, of how we actually strengthen public health preparedness across the nation. Thank you so much. We're now going to hear from our next speaker, Dr. L. Brandon Traxler from the South Carolina Department of Health and Environmental Control. And I do see that our audience is already putting questions into the Q&A. Please continue to put your questions into the Q&A feature, and we will move to questions after we complete the presentations. Dr. Traxler, I'll turn it over to you.
Thank you so much to Dr. Gracia and to Tifa, and for those of you who have joined us today. I am Brandon Traxler. I am one of the deputy directors at the South Carolina Department of Health and Environmental Control. I'm over the Health Promotion and Services Division, which was formerly known as Public Health. We're undergoing some renaming. I also serve as our Chief Medical Officer and as the Vice Chair of the Preparedness Policy Committee for the Association of State and Territorial Health Officials, ASTO. And it really is truly an honor to be here with you all today. Next slide, please. So some of the themes you're going to hear from me at the state level are very similar to those that you heard from Dr. Washington at really the local level. And I think it really emphasizes the point that he made there at the end, that emergencies do not know boundaries, and that response is not limited to one geographic level or even one organizational level. It really impacts everyone and every entity. In South Carolina, we are, I will note, a centralized public health system. So local is state for us. Our local health departments are part of our state health department. First, I want to touch on this broad nature of emergencies. Really, any significant emergency that you're going to have happen out there in the world that's affecting anyone beyond the individual level, that's really affecting any population or subpopulation, is going to have a public health component to it. Some of those are going to be much more obvious, such as the COVID-19 pandemic. Others will be much more subtle, but they all are going to have a public health component to the need for preparedness and response capabilities. I think that one of the big categories, certainly, that we face in public health emergency preparedness and response is the weather-related emergencies, as we've heard from Ms. Gilbert and Dr. Washington. The weather-related emergencies are only getting worse. They're only getting more unpredictable, and they're only getting more severe. The diversity of them is increasing. In South Carolina, we're very familiar with hurricanes. We unfortunately see hurricanes not infrequently, and have gotten to be fairly adept at responding to them. But it is those unknown unknowns, I think, that bother me and that concern me and keep me awake at night. And that includes things like extreme heat, wildfires that we're seeing. No one would have ever really thought, I think, that Louisiana would have some of the wildfires that they experienced in the last few years, but there they were. And again, that's somewhere where we traditionally think of hurricanes. Earthquakes and tornadoes. There's not the anticipation, there's not the knowledge that it's coming the way there is for a hurricane for things like earthquakes and tornadoes. We also, as Dr. Gracia mentioned earlier on in her introduction, are seeing an increase in the intensity of hurricanes. NOAA just last week released their predictions, said that there's an 85% chance of an above normal hurricane season for the Atlantic hurricane area. And so that is something we are very much paying attention to, I think, everywhere along the East Coast. The intensity really and the unpredictability of the models for those, as we see differing models and even ones changing as we go more than we used to, really puts a strain on the system and our ability to respond. We also have to be prepared, as Dr. Washington noted, for all hazards. We have to be prepared for infectious disease outbreaks. We're seeing an increase in those. As we see an increase in global travel, we're only going to see that continue. We're going to see things not only like respiratory, like COVID-19 that can spread very quickly and easily, but we're going to see things like mpox that has come over from Africa. We're going to see, unfortunately, cases of hemorrhagic fever, Marburg, Ebola, things that really do scare, I think, most Americans. We have to be prepared to respond to those because it is truly one plane flight away from the United States. Bioterrorism is another one that, again, this is part of how public health preparedness got its start, but it is also something that is still 23, 24 years later, still present as a risk. In addition, any mass casualty incident has the potential for a public health component. Things such as the Francis Scott Key Bridge collapse in Baltimore, which thankfully was not a significant mass casualty incident, but really could have been if it not for the quick thinking and quick actions of emergency workers there on the bridge. And not only in terms of the direct, casualties and direct victims of the impact and the collapse, but also in terms of potential releases that could have come from the ship's cargo and its impact on the Baltimore community right there. Things like that really do have the potential to have a significant public health response component. Next slide. Could I have the next slide, please, Tim? Thank you. So to be able to respond to these broad, diverse, and unpredictable, unknown unknowns of emergencies, we really have to have sustainable and flexible funding. It is critical for public health to be able to do what it does, not only on that day-to-day basis, but also during the emergencies or during the unexpected. We need to be able to adapt. We need to be nimble, able to respond very quickly and not have delays related to appropriating money or procuring supplies, et cetera. An example, I think, as Dr. Washington alluded to with vaccines, an example is having COVID-19 funding during the pandemic that really, could have been more flexible, could have allowed for quicker response with MPOX. We were able, with the assistance of many federal partners, to be able to use it in ways to help respond. But having those abilities from the start certainly can help in an instant. The Public Health Infrastructure Grant is a great example of very flexible funding, and we certainly hope that it will continue. We need for funding such as this to continue and to not get more prescriptive as we go. Next slide, please. Another challenge that's facing us at the state level for public health emergencies is the need for a robust and really resilient supply chain. We all saw examples and heard about them during COVID-19, the testing supplies and kits and reagents early on, as well as the personal protective equipment, the PPE, but also the drugs and medications. We're seeing antibiotics, which are in shortages. And which, when we have antibiotic shortages, it is only causing people to potentially have to use maybe more potent, let's say, antibiotics than are what's necessarily used, for a condition. That's contributing to resistance. That's contributing to antibiotic resistance when we have shortages of the narrow spectrum antibiotics that we need. We need supply management and logistics capabilities also to be able to handle the supply chain. And to be able to handle the supplies and the drugs and medications and make sure that we're cycling through them appropriately and not causing any wastage during emergencies or in anticipation of one. Next slide. Again, I want to touch also, as others have, on the importance of partnerships. We cannot in public health respond to population level emergencies alone. It just is not feasible, no matter how robust our workforce is and no matter how strong our infrastructure is. When there is a public health emergency, we need to have partners available and standing beside us who are willing to help. We depend on them and we greatly appreciate them. I know that ASTO, our organization, the Association of State and Territorial Health Officials, one thing they do is really help organize partners, especially at a national and state level, to come together. TIFA is another group on here who, even as this example of this webinar, has brought together partners. We need not only those partners within government and within the different levels of government, but we need them externally. I think an example right now with the avian influenza is the need for partners for animal and human health, as well as the Department of Agriculture in states and in cities and counties, as well as at the national level, to be able to come together to respond and to be able to share information so that we're all working together in a coordinated effort. And I do believe that is one thing that South Carolina is doing well, as we are communicating with those partners. And so I think it does put us in a good position as we prepare and hopefully don't have to experience, but are prepared for potential in dairy, cattle, or humans in our state. Next slide. And with that, I'll leave you with my contact information, and I'm happy to answer any questions when the time comes. And I'll turn it back to Dr. Gracia. Thank you.
Thank you so much, Dr. Traxler, and again, for really showing the breadth and depth of what public health does each and every day in terms of preparedness and response. Really appreciate your presentation. So this now concludes our panel presentations, and we're going to open it up for our question and answer period. We appreciate our audience being very lively in the Q&A and putting forward your questions. I am now pleased to be joined by my colleague, Dara Lieberman, who is Director of Government Relations at Trust for America's Health, who is going to help moderate the Q&A. And I'm going to start us off, and then I will turn to Dara. I'm going to actually start off with Jane, actually to you. And we've seen it in the Q&A. You talked about in particular with your work as Chief Heat Officer for Miami-Dade County, how you look at your heat response plans and how you really think about which are the communities, the populations using data, some spatial, geospatial data, to identify populations that are going to be at disproportionate risk for extreme heat. Can you expand on the points you started to raise in your presentation about how you prioritize actually protecting and doing outreach to the communities and populations that are most at risk? And as you've probably seen, there's interest, for example, around outdoor workers and other populations.
Perfect. So just to give a highlight, the zip codes that you saw in the darkest red in that map, they're experiencing emergency department visits and hospitalizations at rates 4 times higher than the other lighter colored zip codes. So the disparity is quite significant between those. And so all our targeted messaging and media, outdoor media, in healthcare clinics, in gas stations, in everywhere we go, in multiple languages, is targeted to those zip codes. And in English, Spanish, and Haitian Creole, we do, Haitian Creole radio, we do Spanish radio, we do social media outreach targeting those different populations. We have specific messaging for pregnant people, specific messaging for outdoor workers. And then we do a series of heat safety trainings that are either in person or virtual for summer camp providers, for our people who are providing assistance to people experiencing homelessness. We do heat safety trainings for their outreach and response. We do also, you talked about building that social capacity in our vulnerable communities. So we started in partnership with our emergency management to do heat safety trainings. This year, it's extreme weather trainings. So we're looking at the trifecta of hurricane, flood, and heat season. And we're partnering now with our community-based organizations to ramp up the recruitment to those trainings. And we're training people not only to protect themselves and their families, but their neighbors, their communities, with ideas for how to do that and with equipment. And so that we actually have the first of 6 in a series tonight on that. Any community that's interested in that kind of training, I'm happy to share the resources that we've developed on that. And then we've partnered with healthcare practitioners to do trainings in the healthcare community as well, to make sure they understand the questions to ask in terms of exposure and how to connect them to key resources.
Terrific. Thank you, Jane. Thank you for that emphasis too, what we're seeing on those community partnerships and engagement and meeting people where they are in the community. Dara, let me turn it to you for some audience questions.
Thank you very much. And let me apologize in advance. It's been a very active question and answer, so we won't get to everyone's questions today. But let me start with one we've gotten from a few sources for Dr. Washington. You spoke about data modernization. Can you really go into a little bit more about what the implications could be for local health and for our ability to detect outbreaks and diseases if we were able to better modernize our data systems?
Sure. I mean, I think as a tangible example, most local jurisdictions or municipalities don't actually have their own disease reporting system. They rely either on a state or usually a state or maybe a regional sort of entity to sort of manage the data system itself. And so what happens in that case is that we are wholly responsible or reliant on the state system to allow us to be able to know what's happening. And so if you think about, I think one of the benefits of COVID, I will say, is that our ability to be able to receive electronic lab reporting really expanded across the country, both for labs as well as other healthcare providers. So that's been a very positive. So the time it takes for a lab result to get from result to report is much shorter. But the time it takes to get from if that report is going to the state, and I don't have real-time access to the back end of the state system, then I have to wait until it gets released to me at a local jurisdiction level, which could be another the delay that it takes for that to occur. So it would be optimal to be able to have systems that allow us to receive those reports simultaneously as well as to allow us to be able to manipulate the data on the back end. One of the things that we are also unable to do because of some of the technology we currently use is we can't do a sufficient analytics on en masse of various elements. So even just a case report by itself is insufficient, right? So, you might want symptom profiles or other information that might not come along with the lab report. And so we end up having to use either the hospital healthcare system access, a separate system for this, a separate system for that. And so I think there's an opportunity really to both improve, enhance the technology we use at the local and state level, as well as federal, because then it also has to get to our federal partners. And that's just on the infectious disease side. I think there's even greater opportunity as well on the non-infectious disease side, where there's so much data flowing and across various systems, both in private practice healthcare systems, that could help us understand the true burden of chronic conditions, for example, in our communities, that we're not able to currently. We're currently relying on, basically survey data as opposed to being able to actually use things like healthcare exchange information, or relying on, variety combinations of electronic medical records to help us inform what's happening on our day-to-day. So as well as to evaluate what's working and what's not working.
Of course, that chronic disease data has huge implications during disasters as well. We've gotten quite a few questions about public health workforce. So let me start with Dr. Traxler and anyone else who would like to answer. But we've gotten questions about what policymakers could do to improve recruitment and retention of public health professionals, as well as preventing burnout in the public health workforce.
Certainly, and I think that that this is definitely a challenge that we face at all levels, and that we face in healthcare as well as in public health. Unfortunately, these days, public health is not necessarily always the most popular field to go into. So I think, removing any divisiveness from any topic around health certainly is one thing that policymakers can do. That would increase interest across the spectrum of all students, and all workforce applicants who would want to go into it. We do need sustainable funding, is one thing I think for building that infrastructure that is our workforce. I tell our team they are our most valuable resource out of all the resources that we have. And that needs to be reflected in our policies that we do put into place, things like paid time off as referenced in the TIFA report, and not only making it available, but encouraging staff to take it. Making sure that people feel supported in using benefits that are available to them. We know that the workforce nowadays is looking for flexibility. And so any way that we can do that, be it telecommuting for jobs and roles that are eligible or to which that is attainable, is certainly encouraged. In addition, I think that that making sure that our staff feel valued, I think that is one thing that the workforce I hear repeatedly from the team is that they are looking for. Our agency director has a saying called "People First," which I think is an incredibly strong, really motto, and shows our staff that they're valued. And in addition, any way that things then resources can be put into place for staff to support really a work-life balance, I think is another aspect of work that the workforce nowadays is looking for, be it childcare, even helping assistants getting spots in childcare, as we know that can be a challenge nowadays, or even subsidizing childcare. But I take that people first a step further and say family first, because we know our workforce cannot dedicate themselves wholeheartedly to the job as well if they have stress and concern about things in their home life. And I think that that's a way that you can combat burnout is by really supporting the work-life balance and not just saying the words, but truly walking the walk.
Nadine, you
Dara, I'll
muted
just
yourself.
add that Dr. Traxler, excellent points. And, the public health workforce is so vitally important when we think about our nation's health security and promoting health and well-being for the nation, communities across the nation. Dr. Traxler raised so many important points around the importance of sustained and flexible funding to be able to meet those foundational capabilities and having a workforce to do so for both chronic disease, infectious disease, environmental health, whole host of areas. And I think that, you know, some of the emergency legislation, which has provided funding into infrastructure, is important. The challenge is we often return to that boom and bust cycle and don't see that sustained. And I think legislation like the Public Health Infrastructure Saves Lives Act, TIFA, many of our public health partners, we have been championing that bill to support the importance of sustained infrastructure investment, which includes the workforce, and also recognizing that public health is competing as well with other sectors with regards to the same workers, and being able to actually provide the salary and benefits that will attract and retain workers. And so the importance of, yes, the fact that public health loan repayment has been authorized, but needs to now be appropriated in order to be able to move that really into implementation, I think are also some critical measures for the public health workforce.
We have time for one or two more questions. So for Jane Gilbert, can you expand a little bit more on what outreach to outdoor workers looks like in Miami-Dade? And also, what are the perceptions that these workers or perhaps their employers have as it relates to heat safety?
Yeah, well, that second one varies, so what we've done is offered free trainings that we've promoted to our higher risk and higher number industries that have a higher number of workers exposed to heat. And for the safety officers, for the business owners themselves, we've done, again, messaging to those communities that link them to a website with all sorts of resources for how to create heat safety plans. One of the things we really try to message is that by having water, electrolytes, by providing shaded rest breaks, you actually can maintain or improve productivity and reduce your workman's comp claims. You're not only protecting your workforce, but you're actually protecting your bottom line by doing this work. It really varies the level of awareness. We've raised awareness a lot in our construction and agriculture industries, but those small scale businesses in the landscaping, property maintenance, roofing, that may be non-English speakers, those are the harder ones to reach, that we're not sure. And we know that there's a lot of pride in workers, that they think they can handle things that sometimes it's often not the case. But we're doing our best to, again, message that through multiple different channels and get more targeted in that messaging.
Thank you so much. And last question, let's start with Dr. Washington. Can you just talk about, during recent emergency responses, where have you discovered the greatest bottlenecks or barriers to coordination, perhaps with across agencies or with partners?
Sure. I think what I would say, of course, what happens so often in emergency response, even with a well-laid plan, is that we are continuing to contend with not just this sole emergency, but the other competing demands that we also must continue to retain. And so having the human resources available to us to be able to mobilize quickly for a response on the ground, as well as to be able to continue our ongoing responsibilities as a local health agency, can be a challenge. I think the other, in terms of just coordination, that can sometimes be a challenge for us locally. In North Carolina, all of our counties have a health department, unlike our neighbors in South Carolina. And so we are left to, there are 85 health directors in the state. And so we have to work together. And fortunately, we have an association that brings us together. But again, thinking about there not being any, infectious diseases don't think about or are not aware of our boundaries, even the state boundaries, where we have so many of our residents that go between North Carolina and South Carolina, very often being a border state. We don't have great tools to coordinate across state lines as a local health agency. And so I think that's one opportunity for us to think about, again, just ignoring the geographic boundaries and thinking about how people operate and making sure that our responses are seamless across even state and county lines.
Terrific. Thank you, Dr. Washington. Thank you to all of our panelists, Dr. Washington, Dr. Traxler, Jane. Really just incredible feedback, resources that have been included in the chat for our audience. Clearly, this is really such an important issue and one that we face each and every day. In closing, I just want to say thank you to our panelists, to AI Media Captioning Service, Keystone Interpreting, to our TIFA team that is with us, helping us to facilitate today's briefing and webinar, and to all of you in the audience for really great thought-provoking questions and your own experiences with regards to public health preparedness. We will have a recording along with the slides and additional resources that have been mentioned in the context of this briefing available on our website at tifa.org in the coming days. So we encourage you to tune in and we will also send out an update when those resources are available. Many thanks for joining us today and thanks for all the work that you do. Thanks, everyone. Take care.